Hello and welcome to today's session on our MDC question style walkthrough. I'm Dr. Kuzi and I'll be taking you through today's session. Today's question says, a 70-year-old man with history of hypertension presented with chest pain. He had a similar episode about 2 years ago, during which he presented to the emergency department with shortness of breath and an ECG similar to this one. Right. And so we are asked to find out what the most likely diagnosis is in this patient. So the options are myocardial infarction, pericarditis, angina pectoris, GERD, which is gastroesophageal reflux disease, and pulmonary embolism. So as usual, we will go to the question itself, try to pick up relevant information from the stem of the question that will help us in answering the questions, and then we will now read the ECG, add those findings together to make a final diagnosis. Right. So from the question itself, the relevant information that is there is that the patient is 70-year-old, which tells us that is an elderly person, and so that's a relevant risk factor, especially when we are dealing with cardiovascular diseases. Someone presenting with chest pain. Is also hypertensive, another relevant risk factor for cardiovascular diseases, and the main symptom he presented with chest pain. He also had a similar symptoms or a similar episode 2 years ago, so which is a relevant past medical history, where he presented with similar presentation, shortness of breath, and had a similar ECG. So from the stem of the question, these are the main factors or the main relevant points from the stem of the question. From here alone, can we rule out any of these differential diagnoses that we've been given? Not really. I mean, without the ECG, we can't really say. I mean, putting all these findings together, this patient is at risk of developing angina pectoris. He can develop angina pectoris. He could have developed a myocardial infarction. He's 70 years. We don't know how mobile he is. He could possibly also develop. So all these differential diagnoses that we have here could possibly occur in this patient, just taking the history alone. Even though the fact that he's 70 years and has some major risk factors for cardiovascular disease will put him more at the cardiovascular spectrum of these differential diagnoses, so angina pectoris, myocardial infarction, and all of that. But without the ECG, it will be very difficult to actually make a diagnosis here, a definitive diagnosis. So let's try and see if we can read the ECG and put the findings together with what we have already to make our final diagnosis. So this is the ECG that we've been given. If you have watched the module on how to read ECG, you'll be familiar with how to do that. If you haven't, please make sure to watch the model on our platform to get more information on how to interpret ECG and some of the key findings that you find on an ECG for a patient with the various common cardiovascular conditions that you see in the clinic. So when you pick an ECG, you should have an algorithm, or you should have a system how that allows you to read the ECG systematically, and so that it enables you to pick up all the key findings there are, and to avoid missing key things. So first thing you need to do is you need to be sure that this patient, the ECG belongs to a patient that you're addressing. So name, age, sex, and you need to be sure of the date of this ECG. Is it the current ECG you're looking at, or is it a past ECG that you're looking at? So you need to confirm all these things. You need to be sure of the rate at which the ECG paper was recorded, because it helps you determine influence when you are determining the rate of the heart rate of the patient. So those are key things that you should identify right away before you start, before you dig in to try to pick up key findings from the ECG itself. Right, so you've gotten that out of the way. First, you need to determine the rhythm of the ECG. Some people always start with the rate, but the rhythm is very good. It's a very good starting point, because it allows you to actually determine what method you are using to determine the rate of the heart. Because if it's an irregular rhythm, the method is different from if it's a regular rhythm. So how do you determine the regularity of the rhythm of the patient and heart electrical activity? So first thing that you want to determine is you want to see that there is a normal P wave, and in this patient, the best lead for doing these things is usually the rhythm strip, which is the lead 2, which is printed down here. And so that's the first thing you want to identify, and you want to see the P waves. Are the patients, the P waves and on this lead, are they normal? Do they look normal? Okay. And so this is a P wave. They look normal to me. And so once you've identified the P waves are normal, you want to find out, do you have P waves following normal? Every P waves, after every P wave, you have a normal looking KRS complex following it. And that is what's happening here. So P wave, KRS complex, P wave, KRS complex, and that is happening here. And so that seems to be consistent. So it's telling us that and you have your RR interval too, seems to be normal, and so this interval between the gaps between the RR the R waves are also normal, and the same thing with the PP intervals. So the P to P, everything is normal. So you have a P wave followed by a normal KRS complex, and you have a normal RR interval. So this tells us that the rate of this patient's heart is normal, and so because of that, because we have a normal rhythm, we can use any of the formulas that are available for us to determine the heart rate of this patient because he has a normal rhythm. The common one is to determine how many big boxes there are in between two successive KRS complexes. So taking this KRS complex, for instance, and the next KRS complex, how many of these big boxes are in there? So you determine that 1, 2, 3, 4, and then you have about half in between there. So you have about 4.5 of the big boxes in between the KRS complexes. So once you've determined that, heart rate can be determined by dividing 300 divided by the number of boxes between the KRS complex, which is one of the common methods you can use. The other methods there, make sure to watch the ECG model again, as I said, to get more information on how to do these, to read the ECG in details. But the common one is to divide 300 divided by the number of big boxes between the KRS complex if the rhythm is normal. If the rhythm is not normal, there's a different method on how to determine the heart rate. And so once you've gotten that, so 300 divided by 4.5 gives you about a heart rate of about 67. And so that means that this patient's heart rate is about 67, 66 to about 67. And so that is the heart rate for this patient. You've determined that. Next thing is cardiac axis. Is there any axial deviation, or the axis is normal? And so one way to determine that is to look at the KRS complex in lead 1 and that in AVF. If these leads are positive, the KRS complexes in these leads are positive, then it gives you a general rule, a clue that the rhythm, the cardiac axis in this patient is normal. So, and that is what we are seeing here, so the normal cardiac axis. Next thing is the P wave. Are they normal? So normal P wave morphology, PR interval. Next thing is your KRS complexes itself. Do they look normal? And this can be determined in all leads, but best determined in lead 2, which is what we've already done. We've identified that the KRS complexes are normal, P waves are normal. And then the next thing you want to determine is the ST segment. So the segment between the S wave and then the T wave, which is where we seem to have some abnormality. So you see that there's an elevation here in lead 2. So the ST segment is elevated in lead 2. If you come to lead 3, the same thing is happening here. The ST segment here is also elevated. And yes, in AVF2 as well, you can see there's elevation of the ST wave and the ST segment in lead AVF. So lead 2, lead 3, and AVF, there's ST segment elevation there. But when you look at that same segment in lead 1, it seems to be depressed. Okay, and then you look at it again on lead AVL, it's also depressed. All the other leads seems unremarkable. So the key findings from this patient's ECG is that we have elevation in ST segment, and these elevations are found in lead 2, lead 1, lead 2, lead 3, and AVF. So those are the key findings in this patient. Yes, so the key findings are what we've identified, and now let's put these key findings on the ECG together with what we have in the stem of the question itself. Now this is the same ECG showing you the same similar annotations that I did, and you have ST segment depression in lead 1, ST segment depression in lead AVL, lead 1, and then you have ST segment elevation in lead 2, lead 3, and AVF. Right, and so those are the key findings in this patient. Now, putting together that together with the findings we already had, we can start to make a diagnosis for this patient. So among all these conditions or differential diagnosis, we know that not all of them will present with these ECG findings that we have, and so we can start to rule out those differential diagnoses. Get will not have these typical ECG findings, and neither will pericarditis, angina pectoris, pulmonary embolism too, similar thing, will not have similar ECG findings. Typical findings, you see tachycardia in those patients. Angina pectoris will not also present with S6 elevation, as we've seen in this patient. And so that leaves the only diagnosis here which matches the clinical presentation and the ECG finding to be myocardial infarction. So specifically in this patient, the diagnosis is an acute inferior wall ST segment elevation myocardial infarction. So this is an ST segment elevation type myocardial infarction. We have a module on ACS, acute coronary syndrome, where we discuss myocardial infarction into details. But we have a non-STEMI, which is a non-ST segment elevation myocardial infarction. But in this case, there's an ST segment elevation, so it's a STEMI. It's an ST segment elevation myocardial infarction, and the infarction is found in the inferior part of the heart. So because we have seen the elevation occurring in lead 2, lead 3, and AVF, and these are leads that look at the heart from the inferior side, and so that is why we have elevation in those leads, and we have a reciprocal depression of the ST segments in the opposite lead, which we've seen here in lead 1 and lead AVL. Again, make sure to watch our module on ACS to get more details on this, but those are the key findings you see in a patient with myocardial infarction, and that makes the diagnosis myocardial infarction. Now let's look at some differential diagnosis of chest pain. So aside ACS, which we've already discussed here, you can also have cardiac tamponade, pericarditis. We already talked about the fact that it can also cause chest pain. All the carditis, so myocarditis and endocarditis can also cause chest pain. Aortic dissection, you have pulmonary embolism, pneumothorax. In addition to all these other differentials, we have other differential diagnoses, so we have cardiac, so you can always group them into cardiac causes, and then pulmonary causes, and you have musculoskeletal causes. So these are the main cardiac causes, and you have the pulmonary causes, for instance, you have pulmonary embolism, tension pneumothorax, pneumonia, exacerbation of asthma, for instance, can also cause chest pain, exacerbation of COPD, pleuritis, so inflammation of the pleural tissues, so the parietal pleura, for instance, is somebody with SLE. These can cause pleural pain. You have pleural effusion. These are all possible causes of chest pain. You have musculoskeletal causes like costochondritis, rib fractures, chest trauma, TS syndrome. These are all possible causes of chest pain. But always keep an eye out for life-threatening causes like the acute coronary syndrome that we've discussed, cardiac tamponade, which is life-threatening cause of acute chest pain, aortic dissection, another life-threatening cause, pulmonary embolism, and tension pneumothorax. These are life-threatening causes of chest pain that you should always keep an eye for when you are presented with a patient with chest pain. Right, but your history will always help you in determining what kind of chest pain it is that you are dealing with. But again, we have separate models where we talk about each of these differential diagnoses into details. So do make sure to look out for these models and watch them for more details. Right, so that concludes our session for today. See you in the next session.